So this lecture is intended to review the updates that we've made in 2023. Not every single update is making it into this lecture. If you want to go and review what has been updated over this past year, just log into your protocol app, go to reference charts, and then go to changelog. That basically has a timeline of everything that's been updated throughout this year. So some of the things we're going to talk about is RSI, pain sedation, traumatic brain injury protocol, whole blood, TXA calcium, ANSEF, the PD dosages and how we updated those, and HANTEVI, the IO sites, and traumatic arrest. So case study number 1, you're dispatched to a possible suicide attempt. The patient is attempting to kill himself with a gun at a gas station. Law enforcement makes scene and clears you in. You find the patient upright and in no apparent distress. Based on your assessment, you find the patient to be depressed with signs of mental health illness. Harris County Sheriff Office, after a period of time, issues an EDO for the patient. The patient refuses to be transported by ambulance. As the cops are trying to place the patient into the back of their cop car, he starts to kick and scream, fighting you and the officers on scene. So you're in a situation where you have somebody who's combative, who you're not able to talk down, who is a threat to not only themselves but to others at this point, and we need to get this patient to the hospital to be evaluated. Not an easy situation to be in. So how do you determine when there is a need for sedation? Obviously, if you have a patient who is altered and combative, but you're able to talk them down or use the least invasive measure possible to safely transport them to where they're not a harm to themselves or others, then that's always the ideal situation. But if you are in a situation where somebody's going to continually fight and be a threat to you and the people around and to themselves, then the best course of action is to sedate them so that you can safely manage them and get them to the hospital. These are the cases that will put you on the news. Incorrectly managing an agitated delirium patient could cause the patient to die, and a lot of the times these become national cases because the media doesn't quite understand what's happening and why we have multiple officers and EMS and fire department all fighting a patient, and we give them a large dose of sedation medication and that person stops breathing, or we don't ever try to sedate the patient and they go into cardiac arrest because of the increased agitation and the stress that it puts on the heart. So how you manage these patients is very important, and there's a reason why our protocol is written a certain way, and that's something that I'm going to talk to you about. So obviously, if you determine that sedation is needed, there are two different medications, two routes that you could go based off our protocols. You have Versed and you have ketamine. And as an in-charge paramedic, you have that decision to make, and I'm kind of going to discuss the differences between the two medications and some of the benefits and some of the negative things that are associated with ketamine and Versed. So how much ketamine can a P2, an in-charge paramedic, administer by themselves? Up to 200 milligrams. That doesn't mean that you always have to give 200 milligrams off the bat. It really depends on the situation, but you can give up to 200 milligrams. I would encourage you to get your supervisor en route. You can still give this 200 milligrams of ketamine, and maybe by the time the supervisor gets there, that patient's sedated. The supervisor can assist you in taking care of that patient. But if that 200 milligrams of ketamine is not going to do it, we're going to need to give a higher dose. And the higher dose that you give a patient, yes, you will hopefully be able to sedate them, but there's also that chance that they could be sedated to a point where now their airway is an issue. And by having the supervisor there, your next step of being able to manage their airway with an advanced, endotracheal tube via RSI is already set up and ready to go. Versed, you can give a max of 10. So it doesn't mean you need to give all 10 at one time. You can start off with 5 milligrams and then progress upwards as needed. So ketamine, the reason why ketamine is used, it's probably the best medication for these situations is because of the quick onset time. So it takes 3 to 5 minutes. So when you are fighting with somebody and you have multiple people trying to control this patient, maybe they've been tased multiple times, it is a dangerous situation to be in. It's dangerous for the patient. It's dangerous for everybody else around the patient, because we're not trying to hurt them, but we're trying to control them in a manner that does not allow any further harm to occur. So you want something that's going to work quick. 3 to 5 minutes is pretty fast for an IM shot. I've honestly seen ketamine work in a minute. So that is super beneficial. Versed is 5 to 15 minutes. It really just depends on how the person's going to respond. I feel like it's taking the full 15 minutes sometimes, which is, again, not the ideal thing when you're dealing with a patient who's combative. Ketamine does not affect your hemodynamics in a patient who has sufficient catecholamines. Remember, your catecholamines are epi and norepinephrine. It's what your body releases to maintain blood pressure on a daily basis, especially is what your body relies on in a shocky state. Now, ketamine and shock is something we'll talk about later, but remember, when these people are in an agitated delirium or just really combative, they have a surge of adrenaline going through their body, which gives them this superhuman strength. So they have sufficient amount of catecholamines, so we're not worried about ketamine necessarily dropping their blood pressure when given. Versed can cause hypotension. It doesn't mean that every time you're going to give Versed to a patient that has, that's altered or agitated, that you're going to drop their blood pressure. It just means that Versed is more likely for that to happen. Versed is very touchy on blood pressure, and everybody responds a little bit differently to any medication you give them. But Versed is one of those where you could give somebody 5 to 10 milligrams of Versed and they're just chilled out and they're fine. Or you can give somebody 5 to 10 milligrams of Versed and you've completely depressed their respiratory drive and their blood pressure has tanked on you. And a lot of the times we really don't know what these people have taken. So giving somebody Versed or a bunch of Versed could potentially tank their blood pressure and depress their respiratory drive. So that's just something to keep in mind. Ketamine does great in bronchodilating, which is why it's very useful for your asthma patients, especially if you're going to have to RSI an asthma or COPD patient. It will naturally increase your respiratory rate. Respiratory depression can occur, but that's at really high dosages, which again, we can give up to 500 milligrams when there's a supervisor on scene. So if there's a chance that we could take away their respiratory drive because we have to give them so much ketamine, it benefits having that supervisor there to help you with that RSI. Versed will decrease respiratory rate and has no bronchodilation effects. Again, it doesn't mean that when you give it, they're automatically going to depress the respiratory rate. It just means that it's more likely to happen with Versed. So you have to be careful with that. So the in-charge administered 100 milligrams of ketamine IM and dispatches supervisor 90. The 100 milligrams of ketamine IM was enough for the patient to be calm, sitting on the ground, but was still combative when it came to trying to move them to the stretcher. Just absolutely would not allow anybody to move them to the stretcher. So it was warranted for further sedation. So the supervisor gave 150 milligrams, so we're about 250 total. That was enough for the patient to be sedated to the point where they were still kind of awake, but they were relaxed enough for us to be able to safely put them on the stretcher. In the back of the unit, it was opted to give a milligram of Versed intranasal, and then another milligram Versed intranasal during transport. And I'll kind of talk about why that happened. But at the end of the day, we did enough to safely transport this patient to the hospital, and that's the whole goal of these situations. Just so that you know, and it's very good education, is how and why ketamine is dosed a specific way based off of our protocols. Ketamine is very dose dependent. The lower dose gives you pain relief. Higher dosages sedate the patient. What's in between pain and sedation is a dissociative emergent phase. This phase is where the patient starts to hallucinate, become altered, could potentially become combative. It's basically a bad trip. They're going through a phase where they're having a bad trip because of the dose that you're giving them, or the fact that you gave them sedation dose of ketamine, but now that medication is starting to wear off, so they're starting to go back through these different phases. So if I gave somebody 250 milligrams of ketamine, I sedate them. The problem is as that sedation starts to wear off, they could go through this dissociative emergent phase where they then become combative again. So the best way to get somebody through that phase is to give them a little Versed. A little bit of Versed will kind of help them relax and work through the hallucinations that might be happening, which is why in this case that patient was given a milligram of Versed intranasal and then followed up with another milligram. Because really 250 milligrams of ketamine intramuscular for a patient who is about 6 foot weighing 250 pounds is enough to sedate them, but that sedation phase probably isn't going to last very long. They're probably going to drop back down into that dissociative phase. So that milligram of Versed will kind of help them work through that phase where they're not going to become more combative with you again. Not every case where you have to give Versed. It's just something to think about. And it also helps, this graph helps us explain why we dose pain medication with ketamine a certain way. So the vial on the left side of your screen and what is currently stocked on the ambulances, if you notice the concentration is 50 milligrams per ml. So the average, in the deltoid muscle, you can only give up to 3 mLs of fluid in a shot. So if our protocol says that a supervisor can give 300 to 500 milligrams, the vial on the left side is not going to be very sufficient if we can only give up to 3 mLs in one shot. So if you are going to give 200 milligrams of ketamine in one shot, it's probably going to end up having to be 2 shots based off the vial on the left. So if you're the in-charge paramedic, you might have to draw up 2 mLs, give 100 milligrams on one arm and 100 milligrams on the other arm. Versus the supervisor on the right side has the high concentrated vial. The high concentrated vial has 100 milligrams per ml. So if they want to give somebody 300 milligrams off the bat, and you already gave them 200 before they showed up, they just have to draw up 3 mLs and give it in one shot. So the high concentrated vials are not on the ambulances for a reason, because we want to avoid potential mistakes, but they're on the supervisor for a reason, so make sure you call that supervisor out if you feel like that patient is going to need more sedation than what you can give them. So let's talk about pain. So what's our pain dosage for ketamine? The pain dosage for ketamine is 20 milligrams, 10 milligrams, and 20 milligrams. We're giving that in increments. And the reason why we're giving that in increments is because we're trying to stay in that pain threshold. Giving somebody 50 milligrams right off the bat could potentially put them in this dissociative phase where they start acting loopy. And instead of them being relaxed and their pain being controlled, they're hallucinating and not having a bad trip. And we don't want to give somebody a bad trip. So you give them 20 milligrams, wait a couple minutes, give them 10, wait a couple minutes, give them another 20. You can give up to 100 milligrams total. So once you reach that 50 max, you reevaluate them. If you feel like they need more pain management, you can then repeat the same process of 20, 10, 20. So the question is, how do we mix it? So you're going to draw up 1 ml, which is 50 milligrams. Put that in 4 of normal saline, and that creates a concentration of 1 cc equals 10 milligrams. So if I have a 10 cc flush, I squirt out 6 cc's, draw up 1 cc of the ketamine, roll it around in my hand a little bit to allow it to mix. Write ketamine if you're able to on that syringe. That way somebody doesn't accidentally push the entire thing. And you just know that every cc is 10 milligrams. So I'd push 2 cc's, which is 20 milligrams, wait a couple minutes, push 1 cc, wait a couple minutes, push 2 cc's, and then reevaluate. So that is how we have our ketamine protocol, and the why behind it is keeping them in that pain threshold. All right, case study number 2. You're dispatched to a shooting. Patient's found in the bathtub. You have a gunshot wound to the head. Significant amount of blood is noted around the patient. Agonal breathing is noted, which is never a good thing. Carotid pulses are rapid and weak. Patient's pale, cool, clammy. No other gunshot wounds are noted. So this was a case that I had at Lifelight. Obviously did not make the scene to actually see the patient in the bathtub. I picked up the patient after they were already, in the ambulance. So this is basically what was described to me. It looked like a self-inflicted gunshot wound. It's a college student. Friends came home, found their friend, found the patient in the bathtub. Bunch of blood everywhere. The blood was dry already, so he might have been there for a period of time. Significant amount of blood loss, agonal, and showing signs of shock. So these are all things that are obviously not good. As we progress the case, once I got into the back of the ambulance, this is what I was dealing with: a heart rate of 170, unobtainable blood pressure. Our pulse ox is not going to read. And it's not reading because we're in such a severe shock state that all the blood is being shunted to the core, and then you have an agonal respiratory rate. What the crew had did before I got there, they had BVM ventilations. They were unable to establish an IV, and then they had bleeding control to the head. But that's I walk in and that's kind of where we're at. And if you're seeing these vital signs and you listen to the patient presentation, it's a peri-arrest patient. It's a patient that's about to die. So first thing is, how would you manage the airway? So we got a BVM. So do we have an OPA in? Are we suctioning the airway? Do we have a high flow nasal cannula in? If you have enough providers, 2-person BVM technique, maximize the amount of oxygen, and make sure we have a good seal. That way we're giving adequate ventilations. We don't have access at this point. I am not wasting time on an IV. Drill. Humoral head IO, 3 seconds directly to your central circulation. You drill these really sick patients. Preferably 2 humoral head IOs, 1 for blood, 1 for your RSI medications. But if you only have time to get 1 IO, you can make it work. So based on these vital signs, is it time to RSI? No, it's definitely not time to RSI. If you try to tube this patient right now, you're going to kill him. The reason why you're going to kill him is because they don't have a blood pressure. And going in and intubating a patient without a blood pressure is very, very risky. So we need to make sure that we're resuscitating before we're intubating, and we're being very picky on what drugs we're giving them to facilitate the RSI. So the best way to resuscitate this patient is blood. Yes, it's a single gunshot wound to the head, but they have lost a lot of blood from that gunshot wound. They are at the point where they are decompensated shock, about to die. So this is a patient where you probably start 1 unit of blood, put an IO in, start a 2nd unit of blood, have 2 units of blood flowing, and get your push dose pressors out. Because if their blood pressure doesn't immediately respond after 1 unit of blood, and you still have that 2nd unit going, this might be a patient you give them 10 mics of levo to facilitate the intubation, so that you can temporarily raise up that blood pressure while you're tubing them. So what drugs would you give? Would you give that 100 milligrams of ketamine? Would you give a shock dose of ketamine? Would you give no ketamine and just rock? Those are all questions that you should ask yourself. Not every case is straightforward. This case is pretty straightforward. This is a patient that's unresponsive, peri-arrest, in shock. This is a rock-only intubation all day long. Giving somebody sedation in this case will probably push them over the edge and cause them to go into cardiac arrest. All right, so let's review a rock-only intubation versus a shock dose, what it says in our protocol, when would you do this. These are very important topics to talk about because people get very confused. Paralytic only RSI, as it's written in our protocol, is somebody who is peri-arrest or unresponsive with shock symptoms. Everybody thinks, or a lot, I'm not going to say everybody, a lot of people think paralytic only RSI means unresponsive patient. No, unresponsive with signs of shock. Okay, and when we get into talking about TBI, we'll kind of re-hit this point again. So this is the patient who is a septic shock patient who is completely unresponsive, right? And you're having to give them a bunch of fluid and levo, and you're regressively resuscitating them, and for whatever reason you need to intubate them, and you don't want to give them something that's going to put them over the edge and potentially kill them, you do a rock-only intubation to facilitate the intubation process without killing them. Once your airway is secured, you recheck your blood pressure, look at your hemodynamics, and slowly start titrating your sedation based off of the patient presentation. That's a rock-only intubation. Now, shock dose ketamine was introduced for the shocky patient who has signs of a mental status, meaning they're altered, they're maybe confused, maybe, they're somewhat aware of what's going on, you sternal rub them, they grimace, they flinch. This is the patient that you're worried about having some form of mental status, and you want to give them a little pain sedation medication, but you don't want to give them too much to kill them during the process of trying to secure their airway. So a shock dose of ketamine is 20 to 40 milligrams, and that's a range because it allows us as providers to be able to determine how much we want to give this patient. Now, how would you mix the shock dose of ketamine? You can mix it the exact same way we did for pain. How it's written in the protocol is take 8 cc's of saline, so take a flush, squirt out 2 cc's, draw up 2 cc's of ketamine, which is 100 milligrams. That creates your concentration at 10 milligrams per ml. 10 milligrams per ml allows you to push that shock dose of ketamine. Obviously, the most important thing is resuscitating your patient aggressively, but it also is very important to know how your drugs work and when to use a paralytic only RSI versus a shock dose ketamine. And again, not every situation is going to be straightforward, but we have to be clinicians and tailor our medication to our patient presentation. All right, let's go to case study number 3. You're dispatched to an unresponsive patient. Love these calls. It could always be anything. It's a 58-year-old male. You find them on the couch, a GCS of 3, last seen the night before. You have no past medical history. Their breathing is 8 times a minute and they're foaming at the mouth. They have very strong, rapid pulses. Their pupils are 4 millimeters and sluggish bilaterally. So what's your differential? How would you work through your differentials to come to a conclusion of what's going on? The first thing that you probably want to address is the airway and breathing, regardless of what the differential is. Foaming at the mouth in a respiratory rate of 8 is not good. We've already checked pupils. They're not pinpoint. We don't really have any significant changes as far as dilation on one side and non-reactive, but they are sluggish. So that's something to be concerned with. Let's check a sugar. Let's rule out hypoglycemia. Let's maybe ask bystanders if they saw any type of seizure activity. No history of seizures, but it doesn't mean that they couldn't have had a seizure. If you're able to, maybe rule out and ask some questions about, recent sicknesses or illnesses or hospitalizations. We also need to rule out cardiac causes, right? We need to make sure they're not in a lethal arrhythmia. They're not having a STEMI. Those are all things that we probably should be going through our head as we're trying to manage the patient. This patient ended up having a head bleed. So pretty massive head bleed. This isn't the picture of the patient's CT scan. This is something that I got off online, but definitely that probably should be somewhere high on your list. Once their sugar's normal, you ruled out overdose, and you don't have any signs of cardiac or infection, then this is probably high on your priority list. So the crew gets vital signs. Heart rate is a little tacky. Your BP's a little elevated, but it's not bad. Respiratory rate is obviously depressed, and that's leading to a low SpO2, and your blood sugar is fine. So remember, patients don't read textbooks. So the fact that their heart rate's not low and their BP's not super elevated does not mean that they don't have a head bleed. Remember, every patient presents a little bit differently, so just go based off of what your physical assessment is telling you. And there are steps that we need to take before we get to intubation. Those basic skills that we do to manage an airway is extremely important. So suctioning an airway, repositioning an airway, using a jaw thrust, or head tilt chin lift, NPA, PEEP valve, two-person provider BVM technique with one person holding a seal with both hands, one person squeezing the BVM. Those are all things to maximize your BLS airway skills. Now, definitively, we need to intubate. And is this a rock-only intubation? And I ask this question because a lot of people, when we roll this out, are stuck with the mindset of a rock-only intubation is for anybody who's unresponsive. And not every single person who's unresponsive needs a rock-only intubation, which is why we put in the protocol peri-arrest or unresponsive with signs of shock. And this patient does not have signs of shock right now. So the crews, they did a rock-only intubation, and those are the vital signs post-intubation. So if you have a head bleed, a dramatic rise in blood pressure is going to increase your intracranial pressure, decrease the amount of blood flow that's actually going to get to the brain, and cause more ischemia and potentially push this patient over the edge. So this is not something that we want to do with patients who are hypertensive, who have signs of increase in ICP. There's a reason why our protocol is written a certain way. So the best thing to do is to give sedation medications. Okay, so what sedation medication would you have used? Now, if you say ketamine, that's fine. In this particular patient, a blood pressure of 158/64, giving somebody 100 milligrams of ketamine may increase their blood pressure, because remember, ketamine does increase blood pressure in non-shock states, but it's not going to cause a dramatic rise in your blood pressure, or it shouldn't, with causing your systolics to raise above 200. So ketamine might have been a good choice in this patient, because we also don't want to give too much medication to potentially drop that blood pressure too low. Normally in traumatic brain injury and head injury patients, Versed and fentanyl are the better choices, because those patients are usually really hypertensive, and giving somebody some Versed and fentanyl will lower their blood pressure, but it lowers their BP, it lowers it down to an appropriate range, and the Versed will help protect the brain from seizures. So a lot of the times Versed and fentanyl are good choices, but again, patients are dynamic, so you have to be clinicians and understand how your medication works and tailor those medications to how your patient is presenting. Let's review the updated TBI protocol that we made this year, specifically in this slide talking about transport destinations. It gives you the map, and you subtracted that by 15 because you assume that their pressure inside their brain is at least 15. That gives you an idea of where your cerebral perfusion is at. So it kind of hits home the point of blood pressure management in these patients are very important. Some little things that you can do to help decrease intracranial pressure is raising the head of the bed 30 degrees. That's also something that's written in our protocol. Doing that allows gravity to take blood in the brain and allow it to pull downwards naturally, so that we're not laying the patient flat and having a lot of blood pooling in the brain. So please pull out Handtevy for this case. You're dispatched to a 2-year-old female. It's in the backseat of a car, unrestrained and unresponsive. During the primary assessment, you note head trauma, abdominal bruising, and lower closed tib fib fracture. Your heart rate's 160, your blood pressure is 70/40, your respiratory rate is 8, your SpO2 is 85%, your BGL is 100. Are those vital signs normal for this age? So what are some things that are jumping out to you that are very concerning? Well, one, we know that airway, breathing, oxygenation are very, very important in a kid in general. So having a respiratory rate of 8 and SpO2 of 85%, that's very concerning for me. I think based off of the injury, the mechanism and the injury sustained, my vital signs are also showing me that the patient is at the point where they're about to go into decompensated shock. And we know that kids don't compensate very well. They compensate very well, but they don't handle hypotension very well. So kids will compensate until they don't. There's not like adults where they slowly, not necessarily slowly, but you have different phases where we're able to intervene. Kids may just go downhill very fast on you. So this is a patient we need to be very aggressive with. So treatment plan would be obviously make sure there isn't any external bleeding, which we kind of already did during our primary assessment. Manage the airway, so suction, jaw thrust, airway adjunct, BVM ventilations, high flow nasal cannula. Access is probably the next thing we need to worry about. So doing a distal femur IO in the uninjured leg, allowing us to be able to resuscitate them with blood products are our main treatment goals for this patient. So how much whole blood can be administered to this kid? So looking at Handtevy, it could be 240 mLs or 20 mLs per kilogram. Now our bags have 500 cc's, our whole blood bags have about 500 cc's of blood. So you give about half the bag of blood. With kids, when it comes to giving them volume, yes, you want to make sure that you're giving an appropriate amount. It doesn't have to be necessarily exact all the time. Just it's not like medication where we're making sure we're giving them the exact amount. With volume, you have a little bit of leeway. So even though it's 240 mLs, giving somebody 250 cc's isn't going to kill the patient, especially when they're in a state when they're in a hemorrhagic shock. So let's say you give them half a bag of blood and you want to give them another bolus. You give them another bolus. You never withhold blood. So there isn't like, oh man, Handtevy says 240 cc's. I don't know if I need to give more. Let me call doc. Doc is going to tell you, why are you calling me right now? Of course, give them more blood. So don't withhold blood from a pediatric patient that is in hemorrhagic shock. Continue to give them blood and resuscitate after each bolus. Reassess after each bolus to see if there's need for continued blood administration. TXA and calcium, can you give this to a pediatric patient? Yes, of course you can give it into a pediatric patient. Our protocols have it to where we can give them pushes of TXA and pushes of calcium. Don't get confused and try to look in the drip section of the 2-year-old and try to do math and try to figure out how you're going to administer it to this kid. No, screw all that. You have a sick kid in front of you, pull out your hand heavy. Hand heavy tells you exactly how much TXA to draw up from the vial, push it. Exactly how much calcium to draw up from the pre-filled syringe, push it. Give these patients these medications as their adjuncts to your blood. So continuing on with this case, do you have to call Dr. Stevens for an RSI of a pediatric patient? Doc recently had us update the protocol. He does not want us to call. He wants you to take care of the patient. So a P3 or P4 can RSI with another in charge, does not have to call for an approval. Call him after the call, let him know what happened and what you did. That way he can discuss and go over the call with you. If you're ever in a situation where you don't know where to go or how to manage the patient, then give him a call so he can give you guidance. So calcium is extremely important to give during blood administration because our units of blood have citrate in them. And citrate is essentially an enzyme that prevents blood from clotting inside the bag. It keeps it a solution so that we're able to administer the blood to the patient. The problem is that citrate attaches all your free calcium. So what that means is that it takes all the calcium that's floating around in your body and attaches to the citrate, which means that dramatically lowers your calcium levels inside your blood. Your body needs calcium in order to clot. Your body also needs calcium for muscle contraction. So Dr. Stevens calls calcium your vasopressor in trauma. Giving somebody calcium will cause some vasoconstriction and increase blood pressure. The trauma triad is becoming the trauma diamond. And the reason why that is because they recognize the importance of calcium in a hemorrhagic shock patient. So as your calcium levels drop due to the amount of blood you're losing, it's also dropping because of the transfusion that is happening with blood products and citrate. The more blood you lose, the more acidotic you get. The lower pH means lower calcium levels. The more blood you lose, the more hypothermic you get, which means your metabolism drops and you're not able to metabolize the citrate inside the blood products. The colder you get, the less likely your body is able to clot. The less likely your body is able to clot is also contributed to the fact that you also don't have a lot of calcium moving around in your body. So this is the trauma diamond, and that's why it's so important to get calcium on board when you're giving blood. So some major things that we added into the protocol when it comes to IOs is the indications and some contraindications. So the preferred site for a pediatric patient is the distal femur IO. That's been in the protocol for probably at least 2 years now. One thing that we added is that a contraindication is for a humoral head IO is a pediatric patient less than 10. They don't have the bone marrow developed. It's mostly cartilage. So it can be difficult, one, to find the landmark. Two, if you think you found the landmark, you're probably just inserting the IO needle in the cartilage, which isn't going to do us anything because there isn't any bone marrow to absorb the medication that you're trying to push into this pediatric patient. The big benefits of a distal femur IO compared to a tibia is that it's a bigger landmark, so you're less likely to miss it or go through the bone. It has better flow rates as well. The landmark for it is 1 finger above the patella and 1 finger medial. Hold the leg, stabilize it, have the toes pointed upwards, put the needle down onto the bone, do slow, gentle pressure with the driver until you feel the pop, and then you stop. The thing that you have to consider is that if you happen to miss or go through the other side of the bone with a distal femur IO, you can't go below the site. So in this picture, they have a distal femur IO in the left femur. If you missed, you can't go to the left tibia. So you have to keep that in mind. Now you can use distal femur in adults. The humeral head is still preferred, but there may be situations where the distal femur is easier to use. We like the humeral head just from the simple fact that it's 3 seconds to sexual circulation, which is extremely important when we're resuscitating a patient. The pink needle is no longer indicated. They should be taking off the unit soon. The pink needles are too small. We don't like small needles. They're a lot easier to come out. The blue needles you can use. You just remember that the blue needle does not have to be flush with the skin. So if there's some of it sticking out, that's appropriate. Also depends on the age, of course. IO reps recommend using the yellow needle for adults when it comes for the humeral head and the distal femur in adults. I think when we see a smaller adult, we want to use a blue needle for the humeral head. They do not recommend that. Remember, with the IO needles, you do not always have to be flush with the skin. These are videos that I sent out into an email. If you're interested in watching them, they're on YouTube. They're very easy to find. Otherwise, I can send you the link. We're going to review the traumatic arrest protocol. I think this is one where people should look it up in the app and sit down and read over and truly understand. And hopefully by me kind of walking you through this and explaining things will help either spark up questions or give you a better understanding of why things are written this way. A lot of what is written in the protocol or what was updated were situational things. So let's get into it. You arrive on scene to a patient who is just involved in an autoped. The engine is already on scene doing CPR. Based off your assessment, you feel like the injuries are compatible with life, so it could be something of the nature of an internal decapitation or a decapitation, or just injuries are, so bad that you don't feel like the patient can be helped or would be able to survive the injuries that they sustained. So the big question is, do you continue CPR and wait for the supervisor to get there? Or if you and the supervisor are there, maybe these are questions for both of you guys. Do you continue CPR? Do you stop CPR and call a DOA? Or do you call doc for a field term? And if you don't know the difference between a DOA and a field term, let me explain it. DOA is basically your medical patient where you arrive on scene and they haven't been seen for a long time. They probably have a long downtime and have signs of rigor mortis. A field term is a patient that you decide to work and you have to do 20 minutes of ALS interventions before you can call Dr. Stevens for a field term. In this situation, it's a DOA. If there were any ALS interventions that were performed, then it has to be a field term. So let's say the in-charge paramedic is unsure if the patient should be worked or not. The supervisor's not there yet. The in-charges go ahead and initiate resuscitative efforts. So you have CPR, BLS airway, maybe needle decompression is done bilaterally, an IO is placed, and the first round of epi is in. Supervisor on scene, Sup does their own assessment, says, hey guys, I think the injuries are, too bad or they're incompatible with life. I think we should stop resuscitative efforts. If that is what is determined, then call Dr. Stevens, say, hey doc, we've done XYZ interventions. We feel like the patient after reassessment has injuries that are not sustainable to life. Are you okay with us stopping resuscitative efforts? And then he can have a discussion with you about that from that point forward. And does every traumatic arrest have to be flown? I think if we would have asked this question maybe 8 months ago or at the beginning of the year, most people were under the general consensus that you have to fly every traumatic arrest. This is something that should be a supervisor's judgment, but you do not have to fly every single traumatic arrest. Speaking from the other side of things, they're never going to tell you not to fly, but I can tell you that it's not very effective flying somebody who has to receive CPR the entire time. What happens on life flights in or any air medical providers in is patient has to be placed on Lucas. In order to load the patient into the helicopter, you have to stop the Lucas, detach the Lucas from the patient, lift the patient up, put them in the helicopter, do your quick walk around, come back in, get the Lucas back on. And then when you get to the destination of where you're going, you have to stop the Lucas, take the Lucas off, take the patient out, Once the patient is out, close the doors and then put the Lucas back on. So the patient honestly is getting a lot of time off the chest compared to if we're doing continuous CPR the entire time. That's probably more effective than um, flying a patient. But again, that's all a supervisor's judgment call and maybe situational dependent, depending on time of the day and traffic. Now, the big thing that that I put at the end of this is that if you place a patient in the back of the ambulance, you must transport. So if we go back to the previous slide and I said that the in-charge paramedic did ALS interventions before the supervisor got there, if the in-charge paramedic prioritized moving that patient to the back of the ambulance and continuing care, well, by the time the supervisor arrives on scene, if the patient's already in the back of the ambulance, you have to go to the hospital. You can't call a DOA or field term inside of the ambulance because that becomes a crime scene and your ambulance will be out of service for hours and you'll be in big trouble. So let's not do that. If transport is initiated, it has to go to a level 1 trauma. So no West Houston, no Herman Katy. Let's take them to the highest level of care, to a place where they could actually do surgery if we're able to get pulses back on this patient. And again, flying a traumatic arrest should be based off of supervisor's judgment. So just letting you guys know, not every single patient has to be flown. And why does the Lucas not get used in traumatic arrest? One, the Lucas hasn't really come out and authorized it for use in traumatic situations. Air medical crews are the only ones that are authorized to use the Lucas. The Lucas also blocks your landmarks to do needle decompression and finger thoracotomy. The top 3 things that kill trauma patients is blood loss, tension pneumothorax, and airway issues. All 3 things that we can address at community. So anytime you have a patient that goes in traumatic arrest and has blunt trauma to the thorax area, so the chest area, or penetrating trauma to that area, and they code on you, you should do 2 needles inside the chest on both sides, 4th or 5th mid-axillary line using the ARS needles. The reason why you do that is to just rule out the potential cause of a tension pneumothorax. And then if you get all your initial interventions done, you've darted the patient, you have an IGL in, obviously CPR is going on, you have an IO, you're giving blood, you're giving epi, you're giving calcium, you're giving TXA, maybe a finger thoracotomy has been done, then we can throw that Lucas on because we've gotten all our initial interventions, and then it's mainly just a safety aspect now. We don't want people having to do CPR as we're bumping down the road. So at that point, doc is okay with us placing the Lucas on the patient. March assessment, if you've never heard of March assessment, there are a lot of good YouTube videos online. This was something created by the military. It's an acronym that always goes through my head when I have a high mechanism trauma patient. It's very easy to be distracted when your adrenaline is kicking or get tunnel vision. So me saying March inside my head helps me prioritize the things that are most important, which is cutting off clothes and stopping bleeding, applying direct pressure, tourniquets, wound packing, addressing the airway, whether that be in a recovery position, jaw thrust, respirations, looking for punctures to the chest area where you would need to put an occlusive dressing, looking for signs and symptoms of a tension pneumothorax, circulation, just doing full body sweeps, making sure you're not missing any wounds. Look for distal pulses, look for signs of shock, treat with hypothermia. So these are all things that are going to be extremely important for your initial stabilization of that trauma patient. And then just re-going over Epi and Levo. So we updated the dose ranges with the pumps to 10 to 20 micrograms a minute. You mix Epi and Levo the exact same way, so you put a milligram in a 100 bag, and that creates a concentration of 10 micrograms in ml. What you would do from that point is then put a syringe in that 100 ml bag, draw up 1 cc to 2 cc's, give an initial push dose, so either a 10 to 20 microgram push dose, and then go ahead and hang an infusion. Once you hang the infusion, your initial infusion rate is typically going to be 10, and you're going to titrate up as needed to 20 to maintain a MAP greater than 65. So just going over that. Hopefully the epi and levo thing, you know that's been in the protocol for a long time, is in regards to how to mix it and make a push dose. The only thing that was updated in this is the fact that you can now titrate up to 20 with the IV pump. Any questions, comments, concerns, things that maybe didn't get explained well, or you just had more questions about, you obviously know how to contact me. Please do. Obviously, protocol changes are a little bit hard to keep up with, so don't be afraid to ask questions and allow me to help you have a better understanding.